Welcome to Study Neuro. In this video, we'll walk through hyperprolactinemia and prolactinomas using a clear step-by-step diagnostic approach every clinician and medical student should know. If you're preparing for exams, clinical rotations, or want a practical framework you can actually use in practice, this one is for you. Join the Study Neuro community for high-yield neuroscience education and clinical pearls on YouTube, Facebook, TikTok, Instagram, and X. By the end of this video, you'll have a clear framework for evaluating high prolactin, avoiding common diagnostic traps, and knowing exactly when imaging is warranted and when it's not. Let's get started. High prolactin levels can be confusing because not every elevation points to a tumor. In simple terms, hyperprolactinemia is when prolactin in the blood stays above the normal range. Women usually have slightly higher normal levels than men, and laboratory reference ranges can vary, so clinical context is important. Prolactin is produced by lactotroph cells in the anterior pituitary gland, and its secretion is tightly regulated. Dopamine acts like a brake, keeping prolactin levels under control, while thyrotropin-releasing hormone can stimulate prolactin release. So anything that reduces dopamine activity or increases thyrotropin-releasing hormone, such as certain medications or hypothyroidism, can raise prolactin levels. In prolactinomas, the lactotroph cells begin producing prolactin independently, without normal regulation. This excess prolactin then suppresses the hormones that regulate the reproductive system, lowering gonadotropin-releasing hormone, luteinizing hormone, and follicle-stimulating hormone. As a result, estrogen levels fall in women and testosterone levels fall in men. So when prolactin is persistently elevated, it sets off a domino effect. Reproductive hormones decline, leading to many of the clinical symptoms seen in practice. Understanding this chain helps you interpret laboratory results correctly and plan a logical diagnostic approach. Now that we understand why prolactin rises, let's see how this shows up in real patients. In women of reproductive age, high prolactin often disrupts the menstrual cycle. You might see irregular periods or even complete absence of menstruation, sometimes accompanied by unexpected milk production, galactorrhea. These hormonal changes can also lead to infertility and a drop in libido, which often brings these patients to medical attention. Postmenopausal women usually present differently. Because their reproductive hormones are already low, they often don't notice typical symptoms. Instead, they may come in later when the tumor grows large enough to press on surrounding structures, causing headaches or visual problems. In men, the story is a bit different. Decreased libido, erectile difficulties, and infertility are common early signs. Gynecomastia can occur, though less frequently. Because men are often diagnosed later, macroadenomas are more common, and visual disturbances due to compression of the optic chiasm may already be present. Speaking of compression, when prolactinomas grow large, they can produce what we call mass effect symptoms. Patients may experience headaches, loss of peripheral vision, especially bitemporal hemianopia, rare cranial nerve palsies, and sometimes hypopituitarism if the tumor starts to crowd normal pituitary tissue. Recognizing these patterns in men and women, along with clues from visual symptoms, helps clinicians suspect a prolactinoma early and guides the next steps in diagnosis. When a prolactin result comes back high, the first rule is simple: don't rush to the MRI yet. Prolactin is a stress-sensitive hormone, so a single elevated value doesn't automatically mean disease. That's why the test should ideally be done in the morning, in a fasting, relaxed state. And if the elevation is mild, always repeat it. Many so-called abnormal results normalize on repeat testing. Once you confirm that prolactin is persistently elevated, the degree of elevation starts to tell a story. Mild elevations often point toward physiological causes or medications. Moderate levels raise suspicion, but are still nonspecific. When prolactin is markedly elevated, well into the high range, it strongly suggests a prolactinoma. And when levels are extremely high, especially in the hundreds, a large prolactin-secreting tumor becomes very likely. So before you move on to imaging, make sure the elevation is real and persistent. This single step prevents unnecessary scans and misdiagnosis and sets the foundation for a clean, logical workup. Once you've confirmed that prolactin is truly elevated, the next question is simple. Is this actually pathology or just physiology? Start with the basics. Pregnancy and breastfeeding are the most common normal reasons for high prolactin, and they must always be ruled out first. Beyond that, everyday factors like stress, poor sleep, or even nipple stimulation can transiently raise prolactin levels. These causes are common, benign, and often overlooked, so they're worth checking before moving further down the diagnostic pathway. If physiologic causes don't explain the elevation, shift your focus to secondary causes. Medications are a big one here. Drugs that interfere with dopamine, especially antipsychotics and antiemetics, can drive prolactin up. SSRIs, estrogens, some blood pressure medications, and opiates can also contribute. A careful medication history often solves the case without any imaging at all. Endocrine and systemic conditions matter too. Hypothyroidism can raise prolactin through increased TRH, so checking a TSH early is essential. Chronic kidney disease can reduce prolactin clearance, leading to higher levels. And even chest wall lesions like trauma or shingles can stimulate neural pathways that increase prolactin release. Only after you've thoughtfully ruled out these common, reversible causes does it make sense to look for a pituitary source. Skipping this step is one of the easiest ways to misdiagnose hyperprolactinemia. Now, here's a subtle but critical diagnostic trap. Not every pituitary tumor that raises prolactin is actually a prolactinoma. Sometimes a non-functioning pituitary adenoma grows large enough to compress the pituitary stalk. When that happens, dopamine can't reach the lactotropes effectively. The brake is removed, prolactin rises, but only modestly. So when you see a large cellular mass with surprisingly mild prolactin elevation, that mismatch should immediately make you think of the stalk effect, not a prolactinoma. Once you've ruled out physiologic and secondary causes, imaging becomes appropriate. An MRI of the pituitary with contrast is the gold standard. At this stage, you're not just asking, is there a tumor? You're asking, how big is it and what is it affecting? You're looking for the size of the lesion, whether it's compressing the optic chiasm, invading the cavernous sinus, or deviating the pituitary stalk. This anatomic context is what allows you to interpret prolactin levels correctly and decide on urgency and management. In short, lab values tell you what is happening, but imaging tells you where and how severe the problem really is. This is where even experienced clinicians can be misled, so let's talk about the classic diagnostic traps. First is the hook effect. In patients with very large pituitary tumors, prolactin levels can be so high that they overwhelm the laboratory assay and paradoxically come back looking low or only mildly elevated. So if magnetic resonance imaging shows a massive lesion, but the prolactin level does not seem to match the picture, do not trust the number at face value. Ask the laboratory to repeat the test using a diluted sample. This single step can completely change the diagnosis. Next is macroprolactin. Some patients appear to have high prolactin on laboratory testing, but very few or no symptoms. In these cases, the result may be driven by biologically inactive prolactin complexes that do not cause the usual clinical effects. When prolactin is elevated but the patient looks surprisingly well, it is worth checking for macroprolactin before labeling it as true disease. Finally, in patients with large pituitary tumors, always think beyond prolactin alone. Large adenomas can compress normal pituitary tissue and cause hypopituitarism. That is why a full hormonal evaluation is important. Checking adrenal function, thyroid function, gonadotropin levels, and insulin-like growth factor 1 helps you avoid missing life-threatening hormone deficiencies and gives you a complete picture of pituitary health. These special considerations do not change how often hyperprolactinemia occurs, but they completely change how accurately we diagnose it. When prolactin is elevated, the diagnosis isn't automatically a prolactinoma. In fact, several different conditions can lead you down the same biochemical path. One of the most common causes is medication-related. Drugs that interfere with dopamine signaling can quietly push prolactin up, sometimes to levels that mimic disease. That's why a medication history is not optional, it's diagnostic. Endocrine disorders can do the same. Hypothyroidism, through increased TRH, can drive prolactin higher, and treating the thyroid problem alone may normalize prolactin without any pituitary intervention. Structural lesions in the cellular region can also raise prolactin indirectly. Non-functioning pituitary adenomas can cause the stalk effect, while other masses, such as craniopharyngioma, can disrupt dopaminergic interdiction simply by compressing the pituitary stalk. Infiltrative diseases can behave similarly by interfering with normal hypothalamic pituitary signaling. And finally, always circle back to physiology. Pregnancy is the most common normal cause of elevated prolactin and must be excluded before labeling any elevation as pathologic. Keeping this broad differential in mind prevents anchoring too early on prolactinoma and helps you arrive at the correct diagnosis more consistently. So, how do you put all of this into a simple, reliable clinical workflow? Think of it as a stepwise filter. You start with the patient in front of you. Do their symptoms raise suspicion for hyperprolactinemia? If yes, the next move is to check a prolactin level, and if it's only mildly elevated, confirm it with a repeat test before going any further. From there, rule out the obvious and reversible causes. Always exclude pregnancy. Take a careful look at the medication list. Screen for hypothyroidism, and don't forget to consider renal or liver dysfunction that can affect prolactin clearance. Only when the elevation is persistent and unexplained does imaging make sense. At that point, an MRI of the pituitary helps you understand the anatomy, but the interpretation must always be paired with the prolactin level itself. A small tumor with very high prolactin points toward a prolactinoma, while a large mass with only modest elevation suggests the stalk effect. And if the numbers and the scan don't seem to agree, pause and think of the hook effect before drawing conclusions. Following this structured pathway keeps you from jumping to imaging too early, avoids mislabeling patients, and leads to more accurate, confident diagnoses. Not all high prolactin levels mean the same thing. The height of the number actually tells a story. When prolactin is only mildly elevated, the cause is often functional rather than structural. Stress, normal physiologic states, or medications are common culprits. In this range, it's more about context than tumors. As levels move into the low to moderate range, think about secondary causes like hypothyroidism or the stalk effect, where dopamine delivery to the pituitary is interrupted. These elevations tend to be real, but they're usually not driven by a prolactin-secreting tumor. Once prolactin rises into the hundreds, the likelihood of a prolactinoma increases. Smaller tumors, macroprolactinomas, often sit in this range. As levels climb higher, especially above a few hundred, macroprolactinomas become much more likely. And when prolactin is extremely elevated, well into the thousands, it almost always points to a large, invasive prolactin-secreting tumor, often with extension into nearby structures like the cavernous sinus. So instead of seeing prolactin as just high or normal, train yourself to see it as a graded signal. The number itself gives you valuable clues about the underlying cause. Most patients with hyperprolactinemia can be evaluated in a structured, stepwise way, but some features should immediately raise concern and change the urgency of your response. Visual field defects are a major red flag. Any complaint of peripheral vision loss suggests compression of the optic chiasm and warrants urgent imaging and specialist referral. Signs of adrenal insufficiency are another emergency clue. Fatigue, hypotension, unexplained weight loss, or collapse may signal pituitary failure, which can be life-threatening if not recognized early. Rapid tumor growth or quickly worsening symptoms should also make you pause. These patterns don't fit with a slow-growing benign process and demand prompt reassessment. And finally, be alert for pituitary apoplexy. A sudden, severe headache with acute vision changes is a medical emergency until proven otherwise. These patients need immediate evaluation and coordinated endocrine and neurosurgical care. Recognizing these red flags early isn't just good medicine, it's what prevents permanent visual loss and life-threatening complications. As we wrap up, remember this one key idea. Hyperprolactinemia is a laboratory finding, not a diagnosis by itself. The real diagnosis only comes when you confirm that the elevation is persistent, rule out secondary and reversible causes, and then interpret imaging in the full clinical context of the patient. A structured approach, starting with the labs, excluding common causes, and then correlating prolactin levels with MRI findings, helps you avoid misdiagnosis, unnecessary scans, and missed red flags. And don't forget to assess pituitary function and mass effect when tumors are large. Those details change management and urgency. If you found this breakdown helpful, join the Study Neuro community for high-yield neuroscience education and practical clinical pearls. You can find us on YouTube and Facebook at Study Neuro, on TikTok and Instagram at Study Neuro Official, and on X at Study Neuro 2025. Like the video, drop your questions in the comments, share this with someone studying endocrinology or neurology, and subscribe for more concise, clinically useful content. Thanks for watching, and stay tuned for the next deep dive.